How was your coffee break? Did everybody get a smoothie? Did you get 2? Maybe 3? A huge thank you to the Cancer Center Treatments of America for sponsoring, Cancer Treatment Centers of America for sponsoring the coffee break. Round of applause. Big thank you for the smoothies. I was talking to somebody on the coffee break and they said that's always their favorite one when we have the smoothies on the Saturday. So hope you all enjoyed it. Did everybody say thank you to one of the volunteers? Yes? No? Maybe? If you didn't, you have another opportunity when we finish. Please do make sure that you stop and tell them thank you for all their efforts, because we couldn't do it without them. So we're down to the final chapter, ladies and gentlemen. We're in the home stretch now, and our next speaker is going to talk to us about 10 big ideas for the next 10 years in healthcare, which I think is a fantastic way to wrap up our conference on embracing emerging trends. And our speaker is Dr. Anna Viamonte Ross, who is the Director of Medical Staff Development at Baptist Health International. She's Florida's first state Surgeon General and the first woman and Cuban American to serve as the head of Florida Department of Health from 2007 to 2011. She was charged by the Governor of Florida to act as the state's leading advocate for wellness and disease prevention. Her primary responsibility was to oversee one of the nation's most comprehensive and complex public health care systems and Florida's largest single clinical enterprise. Approximately 20,000 employees serve in Florida's 67 counties with more than 300 clinical delivery sites. Dr. Viamonte Ross is currently the Associate Dean for Women in Medicine and Science and Associate Professor in the Department of Humanities, Health, and Society at the Herbert Wertheim College of Medicine at Florida International University. And she has responsibility for teaching, evaluating curricula, and improving academic programming at an institution whose vision centers on leadership in developing physicians to work in communities and discovering innovations in the science of medicine and the delivery of patient care. Dr. Viamonte Ross graduated from the University of Miami School of Medicine and the Harvard School of Public Health. She is committed to community service, serving as a board member on the Camillus Health Concern, and volunteering on numerous medical mission trips with Health Through Walls throughout the Caribbean. Dr. Viamonte Ross is going to talk about 10 big ideas for the next 10 years in healthcare. Please join me in welcoming her.
Thank you, Ms. Ahrens, and thank you all very much for having me today. I just want to put on my public health hat for a moment before I get started and remind you all, as far as the flu vaccine, this isn't just for yourself, but for those around you. And I remember growing up with a mother who was severely immunocompromised and disabled most of my life. We all had the flu vaccine, not necessarily for us, because we were healthy, myself, my husband, my children, but for her. And now I'm going to be a grandmother ×2 by the end of the year. And so we are all getting ready for those babies, and again, getting our flu vaccines as well as our booster shots for some of our immunizations, again, to protect those new babies. So again, not just for yourself, but for those around you, make sure that you are immunized and that you're protected. So again, thank you so very, very much. I know that most of you here in the audience work in healthcare and certainly understand the industry, and I'm going today to give an overview of what healthcare will be like in the next 10 years, focusing really on trends that I've seen not just in my work in the United States, but also throughout the Caribbean and in Latin America. And I'm going to talk about some of the main drivers behind these changes and what really large healthcare organizations around the world are doing about it. So let's get started. Let's see if I figure this out. Oops, I'm sorry. There you are, okay. So why is healthcare really changing so quickly? Well, certainly there are a lot of different factors at play, and you've heard a lot about them in some of the lectures during this conference, but they really boil down to 3 main components: social factors, legislative mandates, and certainly better technology, and we're going to touch upon those throughout the talk. First, we know, as Dr. Cleary had mentioned in his previous talk, the world is aging fast. The graph here that you see on the left shows that the proportion of people over the age of 60 has increased 50% since 1950, and it is expected to nearly double again by the year 2050. As another example, in the year 2009, 1 out of every 8 Americans was over the age of 65, and it's expected that by the year 2030, that number will have doubled to 72 million people, or 1 in 5 people. So the world, again, is getting older, but there's also a lot more chronic disease. And as you can see from the graph here on the right, the number of people with chronic disease is increasing steadily and will so over the next 15 years. We know, again, that chronic diseases are already the leading killer, as Dr. Cleary had mentioned, nearly in every country in the world, and it leads to significant functional as well as psychological impairment that we all need to deal with. It is also much more expensive to treat than acute illness. In fact, 86% of all healthcare costs in the United States, or that the equivalent of that is $316 billion annually, goes towards chronic disease care. And again, as you can see on the graph, the costs are only going to go up. There's going to be a lot of data in a lot of these slides, but please know that all of this is going to be available to you on the website afterwards, so don't worry about capturing a lot of this data. So again, as people age and suffer more of this chronic diseases, the cost of care is going to be increasing. In America, where we spend, and I know you all know this, 1.5 times more on healthcare than any other country, healthcare costs are still growing faster than our gross domestic product, despite many years of legislative reform trying to curb these costs. But this is not just an American problem. Around the world, costs are also rising quickly. In fact, the OECD, which is an international economic group, estimated that without significant cost containment, the average national healthcare spending would rise from around 14% of our gross domestic product to around 12% of our gross domestic product by the year 2060. So healthcare cost containment is also becoming a crucial concern for developing countries as well. As developed countries. So although we're spending so much money on healthcare, so much of what we spend, believe it or not, is unnecessary. The Institutes of Medicine, which is a quality evaluation group in the States, did a study in 2010 to find out how much spending was actually wasted. The answer was nearly 1/3. 1/3 of all spending, or in this case, $750 billion, is wasted every year on what is called low-value care, such as putting stents in the hearts of patients who don't need it, or doing CT or MRIs for stable chronic low back pain. This $750 billion is more than the entire grade school education budget in the United States. There's not only been a lot of low-value care, the amount of that care has been increasing for a long time. For example, between 1997 and the year 2005, the U.S. national spending on back pain patients increased over 65%. But there has been no insignificant improvements in the level of back pain reported by these patients. Nearly everyone gets low-value care at some point, and in fact, many of you perhaps have gotten that in this past year alone. The Institutes of Medicine report found that in the States, almost half of patients get at least one unnecessary point of care every single year. But again, this is not unique to the States. In the United Kingdom, unnecessary care also accounts for 15% of all healthcare spending, or around $3 billion a year. Many other countries are just starting to look into their own numbers, but some very early estimates show that most countries likely fall between 15% and 30% in the waste range. At the same time as people are becoming more concerned about cost, we're becoming more concerned with increasing value. Value-based healthcare involves creating healthcare that delivers a big bang for our buck. For example, changing a pre-diabetic patient's diet now so that they don't become diabetic, rather than treating all the complications of the disease in years to come. Primary care provider shortages also will be a continued problem. While we work on one hand getting people to become primary care physicians, non-physician professionals such as PAs or physician assistants, anesthesiology assistants, nurse practitioners will grow substantially in number and assume many of the activities that now are provided by doctors. And that's certainly a big issue in the United States, a big issue in Florida. When we think about the big issues in healthcare, we often talk about the big diseases. And again, Dr. Cleary had mentioned these: heart disease, cancer, stroke, or diabetes. But again, medical error is also one of the top 10 causes of death in many, many countries, up there with these big five. 43 million people around the world are injured every year due to unsafe medical care, such as miscommunication, the wrong medication being given, or even the wrong dose. Governments are realizing that we need to do a lot more to ensure healthcare is part of the solution and not part of the problem. In the United States, the National Quality Strategy was launched in 2011 with the Affordable Care Act, and it's trying to ensure care is spent on improving care quality. A series of priority initiatives to seek to improve quality at the national level by improving reporting and measurement and using pay incentives as well as health IT, among others. One aspect of quality improvement is promoting transparency, particularly helping patients and governments understand how their money is spent and whether certain tests are necessary or are not. If you're on the market, certainly for a new car, and we've all been there, you generally get the price tag at the time of advertisement. But in healthcare, most patients do not know the cost of care till after the service has been delivered. A study by the California Healthcare Foundation found that more than 25% of all patients were not able to find out how much their care costs, even if they were looking for it at the hospital. Very few patients go to the hospital with an understanding of how much they are expected to pay and do not have the tools to help them make these informed decisions. In many countries, providers bill different payers differently for the same services. Wait times are unknown, and prices vary significantly between different providers, even for standardized services such as lab tests and mammograms. And this is becoming a huge issue for all of our governments trying to improve healthcare. At the same time as the government is making these great changes and emphasis, we are moving towards an age where cloud computing is becoming more and more prevalent. Data is becoming more secure, and organizations are realizing the need to make healthcare data available and accessible for all of us from many, many locations. If you've ever watched a video on YouTube, had a meeting through Skype, made a comment on Facebook, written an email in Gmail, you've all made connections through the cloud. Cloud computing is becoming ever more prevalent. In fact, KPMG and Gartner estimate that over 36% of all digital data will be available through the cloud just by next year. So as the cloud becomes larger, it's easier for devices to connect to it and to each other. And that gives rise to the concept of the Internet of Things, the idea that wirelessly connected devices can share data with each other through cloud-based platforms and allow users in very different locations to control devices somewhere else. Here we go. One thing we could be a lot better at leveraging the cloud for is electronic medical records. It's obvious that well-functioning EMR systems can prevent medical errors, reduce unnecessary testing, and certainly improve quality overall. But we could be definitely doing a lot better. This table here that you can see shows the maturity level of different health systems in adopting EMRs. You can see here that only 3% of hospitals and health systems met the criteria for stage 7. Most hospitals were still sitting at around stage 3 or 5, whereas nearly 5% of hospitals still do not have laboratory, radiology, and pharmacy services available. So there is a long way to go. Genomic sequencing also has moved into a central role in advancing human health. Our capabilities in reading genes and identifying mutations has increased dramatically within the past 20 years, and they've largely been accelerated by the Human Genome Project. This project was an ambitious initiative to fully sequence all 8 to 9 billion base pairs of a single human genome. It took almost 12 years to do so, but during that time, it really was a catalyst for improving DNA sequencing technology. That first genome, again, took 12 years to sequence. Now it just takes a couple of days. Back then, it cost over $1 billion. Today, it costs just a few $1,000s, about the same as a sophisticated medical test. But what do we use gene sequencing for? Well, for one thing, finding out the genetic basis for disease. Before the Human Genome Project, we knew the genetic basis for about 60 disorders. Now, we know the genetic basis for nearly 5,000. More than 100 different drugs are now packaged with FDA information that tells all of our doctors to test their patients for genetic variants linked to efficacy, to dosages, and also to risky side effects. Whoops, sorry. As we know more about how they govern illness, we also are getting better at creating gene therapy to edit the genome. We are also having huge advances in something called precision gene targeting. 2 years ago, scientists discovered something called the CRISPR gene therapy, which is a DNA cutting technique that really allows us to edit or to cut our genomes, and it's much cheaper and easier than before, and this really paves the way for allowing us to replace these mutated or defective portions of our genes and treat diseases like cancer, like sickle cell anemia, like cystic fibrosis. These social, political, and technological drivers have generated what I'd like to discuss further today as the 10 major trends that will greatly shape the way we deliver healthcare moving forward. So let's talk about each one of these in turn. First of all, the most interesting thing about rising costs of healthcare is that 5 of the most expensive diseases, again, cancer, diabetes, lung disease, heart disease, as well as stroke, can be largely prevented. As we know, however, only a fraction of every dollar spent on healthcare actually goes to prevention. And we've all seen it. The politicians, our legislators talk a good talk on prevention, but there's little money put into that. But this is slowly changing, and our government's initiatives focusing on preventive health certainly are picking up speed. The old adage, an ounce of prevention is worth a pound of cure, is really ringing true these days in the ears of all our governments. On the technology side, genetic marker screening to prevent cancer, biosensors that can detect movement and location to improve safety, cancer vaccines, of which we already have 2, the hepatitis B and the HPV vaccines, vaccines against inflammatory markers that will help dampen the immune response of a lot of our inflammatory diseases like arthritis, inflammatory bowel disease, and others, all part of this picture. I don't think it's going to come to a surprise to any of you all when I say that a lot of patients would actually prefer to have their healthcare providers become more accessible. We've also had this technology around for many years. Email, phone, text, voicemail. They're all possible ways for providers to connect better to their patients. According to a recent survey, 85% of patients think that email, texting, or voicemail are as good as an office visit. If these elements are integrated into a patient's care, it can drastically improve how valued patients feel and makes it more likely they'll return to the healthcare provider again and again. A few areas where setting substitution is becoming extremely important are mental health and rehab. Mental health services are tragically limited in most areas of the world, and as we know, this is particularly the case in rural areas. There are a few online resources, even that are free actually, such as something called Mood Gym from Australia, that are now available to patients with anxiety and with depression. These websites provide free, self-guided cognitive behavioral therapy, which is a form of treatment that works equally well or better than prescription medications for mild to moderate cases. Rehabilitation is also finding new avenues. For example, allowing patients via teleconference to access physiotherapy at home when they are less able to make it actually to the physician's office. As patients get more services delivered to them at home, they're also becoming a lot more savvy about their own health care. In the United States, 2 in every 3 Americans go to Dr. Google first. 59% of Americans look online for health information, and 35% have tried to self-diagnose online. Patients are also buying more diagnostic strips, getting second opinions from physicians online, and buying prescription medications online. It also looks like patients are very willing to get involved with new media for healthcare. A recent McKinsey is a big consulting group in the United States and throughout the world, surveyed and found 3 myths involving patients and their healthcare. The first myth states that people don't want to use digital services for healthcare. Well, in fact, 75% of respondents were interested in using some form of digital service for healthcare, and the only time they were not interested in adopting digital services is when the available services do not meet their needs or the services are of low quality. There is a lot of demand from patients to get involved with their own care. The survey showed here that you can see on this table that patients in Germany, the United Kingdom, and Singapore were highly interested in getting more information from physicians through many ways besides just the traditional office visit. Listed here are various channels of getting healthcare information: websites, email, smartphone apps, as well as traditional ways of getting information. The blue area shows the more interested people were, the more frequent care per year through these channels. And as you can see, many patients are very comfortable with the idea of getting much of their basic health care through phone, email, and again, by phone. In Singapore, in fact, people seem to be especially keen on this new technology. You can see a lot more blue under the Singaporeans. Myth number 2, only young people want to use digital services. Well, again, the McKinsey survey found that older people, especially those over the age of 50, wanted to use digital services almost as much as younger people. The channels, however, that older people and younger people preferred were different. Older people preferred traditional online channels like websites and like email, while younger patients had stronger preferences for apps and for social media. Number 3 myth, people only want innovative new ideas with apps. Well, the reality is that patients want surprisingly mundane offerings: efficiency, better access to information, integration with other channels, and the availability of an offline person if the online offering does not give them what they need. Patients thought that the most important thing in online health platforms were surprisingly basic, like speed of service, availability, and the direct usability of those services, rather than particularly innovative products or devices that did something new and very different. Basic things might be as simple as being able to connect their own blood pressure at home and transmit that information to their doctor, rather than going all the way down to the office for a checkup, or monitoring their asthma through an online portal and having systems in place to follow up with that patient if something is off. Another trend, here we go. Another trend in patient empowerment is empowerment through choice. Among the new services rolled out under Obamacare, our Health and Human Services Division in the United States publishes now information about health plans, rates them according to quality, and allows consumers to choose the one that best fits their needs. The United Kingdom takes this one step further and involves actually patients in national level decision-making. Patients can rate hospitals and doctors on the quality of their care and government-organized platforms. And patient satisfaction is a tool used in determining how much doctors and their hospitals get paid every year. All the National Institutes for Clinical Excellence, which make many of the health policy decisions, again in the UK, and recommendations for the country, must have at least 2 patients involved as members on their committees. Patient empowerment is also leading to more transparency and cost comparisons. Some independent pricing sources in the United States have now come up to allow patients to compare medical fees for specific services. These services also offer advice for patients on how to control their own medical costs, such as asking your doctor to provide a quotation on the cost of medical services prior to undertaking that service. Health insurers are also getting in on the game. For example, United Healthcare as well as Blue Cross both have cost containment estimators that predict the out-of-pocket costs based on a customer's policy as well as whether they've met their deductible or not. One way that patients can be empowered more is by providing more accurate real-time data about their own health. Many people have heard about Fitbit, and maybe some of you in the audience have it on right now. This is a wearable device that helps people track their steps, their heart rate, and other basic health indicators. These devices, while largely sold as consumer products, also have huge potential in clinical care, particularly for the elderly. Wearable devices can also help avoid hospitalizations, reduce readmissions, and increase the efficiency of care and speed the time for intervention. These devices are frequently worn around your wrist and can act as fall detection sensors for the senior at home and will immediately and wirelessly send an alert message if it detects sudden movement. Many wearable devices can now monitor basic vital signs like heart rate, blood pressure, oxygen saturation, and even insulin levels, and can wirelessly transmit this information to the patient's healthcare provider. Some other device innovations expected very soon will even be able to track the number of coughs of a patient or the number of trips to a bathroom. Worldwide revenue for telehealth services will grow, is expected from $440 million in 2013 to over $4.5 billion in the year 2018. So when it comes to health, as with anything else, the more attention you pay to your health, the more likely you'll improve it. The American Council on Exercise believes that wearable technology, calorie trackers, step counters, and even sleep monitors will boom in the next 5 years, especially with the launch of this year of the iWatch that many of you have read about, and certainly the success of the Fitbit that I mentioned back in 2012. As mobile devices become more sophisticated, there are better and faster ways to connect with your doctor. Telehealth, which is essentially remote healthcare access, is expected to grow exponentially. And between 2013 and 2018, the number of patients using telehealth is expected to increase tenfold. Telemedicine is particularly good at addressing some of the major gaps in our healthcare system. Again, a growing elderly population with more difficulty getting to the clinic, fewer doctors and nurses, especially in the primary care specialties, and again, for those living in remote areas. We can do more with telemedicine than we can with traditional face-to-face contact frequently. Telemedicine can also be a better fit for the patient. For example, Partners in Healthcare in Boston reported that home monitoring reduced readmission by over 50% for those with congestive heart failure. These telehealth systems don't have to be complicated. They can be as simple as calling, emailing, or even texting a patient for reminders or appointments. And although these services are frequently automated, they can be made to be felt one-on-one because they can be personalized and targeted to a patient's needs based on their health records. Telehealth can improve patient adherence to treatment. In fact, a survey by Televox last year showed that more than 35% of patients who did not follow exact treatment plans said that they would be a lot more likely to adhere to directions if they received reminders from their doctors via these methods. The Ochsner Health System in Louisiana is among the healthcare providers who have successfully leveraged this technology. It deployed an automated phone campaign to more than 3,000 patients who had been ordered to have colonoscopies or upper endoscopies but had not scheduled their exams. The phone messages even offered patients the option to book the appointment by pressing a key while they were online. Of the patients reached, over 20% made the appointment. This was a win-win for patients and providers. Colon cancer detected early and treated early has close to 100% success rate in many cases. The patients in the study told Ochsner that without this automated notification, they never would have completed the test. As for the health system, Ochsner generated more than $600,000 in revenue just by conducting these tests. Here we go. Whoops. Other systems have also found great success using telemedicine for cost savings. A pilot study reported in Health Affairs back in 2011 found that telemedicine monitoring of patients' vital signs and other health parameters would create an 8 to 13% cost reduction compared to traditional care. And in this particular system, they saved, on average, $300 to $450 per patient. To support this system, however, we're going to need very good information management capabilities. Data integration is where this comes in, and there will be lots of efforts going towards ensuring IT systems that are well connected within all of our health systems. Texas Children's Hospital provided a great example of how an integrated platform can be used to improve quality and outcomes within a hospital. One example where they used this service was for the emergency department targeting specifically asthma patients. Using this integrated platform, the clinical outcomes team was able to quickly assess that 65% of all patients would receive chest x-rays, although the guidelines recommended that only 5% of the patients receive them. Along with data integration within and between hospitals, there's the larger concept of big data, which involves integrating and extracting information from a variety of different sources, often unconventional, to generate new insights. For example, this I found so interesting. Google was able to look at its search keywords involving flu symptoms, runny nose, and so on, and map the frequency of these words to the locations where the searches were coming from. And that was used to predict flu outbreaks in the United States. In 2014, they were able to predict the flu season just based on search keywords and geography to within 90% accuracy. Another big trend, one that has been ongoing for some time, is changing the way we pay doctors and hospitals to better reflect the outcomes that come from that. The current standing model in many places is still fee-for-service. That is, care is volume-based. You see one person, you get $1. You see 30 people, you get $30. But in our cost-saving society, it's obvious that this model has its faults. First of all, it incentivizes doctors to over-test and over-treat. Second, it does not have any measures to reward the quality of the care being provided. Results-based payment, or compensation that reflects how well you did your job, is replacing traditional fee-for-service practice. Gradually, hospitals and healthcare systems are tying more and more of a provider's income to the results of their care. As you can see here, the potential for compensation increases, but depends more on how much of your population is vaccinated, for example, or how many of your patients were readmitted too soon after being discharged from the hospital. These alternative payment models are taking up more of the total proportion of programs in the United States. You can see here that the target is that 30% of all providers are on some kind of alternative payment model by the year 2016, with half of all providers on such a model by the year 2018. and the rest on quality-linked fee-for-service models. Of course, these models need to be supported by a very robust IT system that will allow insurers as well as government payers to properly understand how our providers are performing. Various health systems are also looking for ways to improve on the way doctors not just get paid, but also how they serve some of their older patients who have a lot more complex health issues and certainly take more time. So here's a quick lesson on how doctors will get paid. Most doctors around the world, again, are getting paid a fee for service. However, which equals, again, getting a fee for every time you see a patient. However, that, again, incentivizes doctors to overtreat and oversee patients, and this often can lead to unintentional adverse outcomes. So many healthcare payers are moving towards something called the capitation model, where care is delivered on a per-patient basis. That is, each year that a doctor sees a patient, they get a certain fee. This fee will differ depending on the age of the patient and the amount of complexity of their care. But this, in theory, should encourage doctors to keep patients healthy, since a doctor does not receive additional payment when the patient is sick. In between the two are something called bundling payments. One iteration is something in the United States called the diagnosis-related groups, the DRGs. It's a system you commonly use in paying for your car's maintenance. There is a fixed fee for servicing, let's say, your brakes, regardless of the amount of work it takes. This method is meant to simplify payments to hospitals by making a set of payments for each patient based on their diagnosis, which should simplify that accounting and calculations involved, and in theory, hopefully, will rein in costs. On the biotech side, one exciting trend developing is that of something called precision medicine, customizing care to a patient's molecular or cellular attributes. Precision medicine is probably making its biggest advancements in cancer medicine. As technology for DNA sequencing improves, we are able to provide more targeted therapies for cancers. It is now thought that as many as 70% of tumors might have specific molecular sequences that can be targeted by medications. Already, patients with breast and lung cancer, as well as many other cancers, undergo molecular testing as a routine part of their care. Some companies, such as Foundation Medicine and Genomics Health, are making great headways into targeted therapies that will improve the way we think about healthcare. In the 2015 State of the Union address by President Obama, he announced a $216 million investment to create a precision medicine initiative, which would include right now a database that would warehouse the genetic information of more than 1 million American volunteers. In the realm of medical safety, we also know that doctors aren't perfect in their diagnostic abilities. Computerized order entry and electronic medical records, for example, have helped to lower errors in prescription and prevent over-testing. The next step is for something called predictive analysis. I don't know if any of you watched Jeopardy, but this is a computer that was designed by IBM called Watson. And in 2011, it made history by beating both of the players that had won the most in the history of Jeopardy, Ken Jennings and Brad Rutter. Ken had a 74-game winning streak, but the final results showed that Jennings won at $300,000, Rutter at $200,000, but Watson, the computer, won with a dominant $1 million. Predictive analytics has long been anticipated, but we're finally able to get a little closer. In fact, Kaiser Permanente has developed algorithms using its electronic health record data to identify diabetic patients most at risk of developing dementia, and subsequently create early intervention programs for these people. Watson, for its part, has digested thousands of medical texts and patient notes, and trials now have shown that it has almost a 90% accuracy rate in predicting diagnoses and helping clinicians answer complex medical questions. So as we go forward, we prepare ourselves to better adapt to new ways of dealing with the world and adapt to new technologies as they come out. These new trends have great potential to reshape the way we imagine healthcare today and help us reach our goals of delivering better healthcare for everyone. At Baptist Health, this is my contact information, and Rebecca Brooks is here on the front row. We're here to help you, to support you, to welcome you if you would like to come, to do observerships, to join us for any of our telemedicine initiatives, as well as our webcasts with CME credits granted. So again, if I could be of any service, or Rebecca, to any of you, please let us know, and we welcome you in Miami, even though you have paradise here already. So thank you very, very much.